Giovanna Imbesi, and welcome to LACNETS. This is the Los Angeles Carcinoid Neuroendocrine Tumor Society. That's why we use the acronym. And this is our monthly meeting. We're very excited to be in our new home here. And our meetings will be on the second Tuesday of the month starting at noon. This is an anomaly in January, just to work out the schedules right. So we hope to see you back. The next meeting will be February 10th, Tuesday at 12 noon to 2 p.m. And we will have a guest speaker at each meeting. And a couple of dates I wanted to let you know about. One is March 1st. There's a conference coming up with Caring for Carcinoid Foundation up at Stanford. It's with Stanford, UCSF, and Caring for Carcinoid Foundation. So a few of us are going up there, and we'll be there for that. Hello. And I'd like to introduce Ziva Naghiyeva, who is filling in for Cynthia Kofelt, our usual facilitator. She's a licensed clinical social worker. And a lot of people have been asking about some of the more psychological effects and wanting to speak with somebody. So Ziva can talk with you about that. She's on staff at Cedars. And if that's something that's of interest to you, please see Ziva. What else? I just came back from the ASCO GI conference in San Francisco. Dr. Wallen sends his love. He said, I miss my patients very much. And there was actually a neuroendocrine panel specifically dedicated to neck cancer with physicians from all over the world. And I imagine they'll put those videos up soon. But that was great to see, and there's just lots of options for us and new modalities being discovered all the time. And we are planning a conference as well for LACNETS, coordinating the schedule of all of these physicians and the room at Cedars and Caring for Carcinoid, who's partnering with us, has been a little challenging, but we're now looking at June 13th, and so we'll hope that the room becomes available and that we can do that. LACNETS is a 501c3. We're a nonprofit, and we have been running kind of on a shoestring for over 2 years now since the group was started. And if anyone here would like to help out, or if you specifically would like to partner with another patient, so there are several patients here who are newly diagnosed. Maybe they're a lumnoid, and maybe there's another lumnoid in the group who'd like to speak with them and maybe talk about their experience. If you're a little further along, we also have some veterans here who've been here for quite a while. Please contact me, because I like to match patients with other patients. And so the format today is going to be, it's amazing we have everybody in one room, Dr. Nissen and these wonderful physicians who he will introduce. And this is a sort of mock tumor board of what actually happens. And the reason we're set up this way is Dr. Nissen said this is the way we do it, so we want it to look like that. So what we'd like to do is save any Q&A for afterwards. This is sort of like we're in the room observing what might actually happen when they're discussing our cases. And so I will go ahead then and please introduce, he really needs no introduction, but Dr. Nicholas Nissen. Thank you.
Well, thank you. The idea behind today was to show 3 cases that are a little bit contrived. They are real patients, and they're all de-identified. And we're trying to move rapidly through them to give you a little bit of a sense for how we work on our Monday meeting. Now, you all heard about this Monday meeting, or many of you have. Going back 5 years, I would see you on Tuesday, you'd see Ed Boland on Wednesday, then you get your MRI Thursday, and you have to come back the next Monday to see me again. Before you knew it, it was 4 trips to Los Angeles. And one of them probably would get canceled, so that adds a 5th. So what we did a while ago was we started to at least see people together on Thursday afternoon at the cancer center. That cut out 1 trip. I many times have offered to do the MRI the same day as your visit. That might cut out another trip. But then the Monday morning meeting became a way that we could all get together around a table and talk about all the pertinent issues And then hopefully that lets your case be put front and center, discussed with all the different doctors caring for it. And so what I'm going to show here is a few slides about that concept. And then when a few others get here, Dr. Hendifar and Dr. Friedman, and hopefully this will work out timing-wise, we will actually show the cases. And again, what I'm hoping, and we haven't done this before, but we're hoping this works, is to talk very much like we do Monday morning. Yeah, we talk a little fast. Yeah, we assume each other knows the terms. And by the way, sometimes we pretend to know the terms as well, and we just nod while the other person keeps going. But a lot of times we'll raise our own hand during the meeting and ask for clarification, or we'll have sidebar issues we'll discuss. And again, the goal is at the end of each presentation, we have a plan of care. The plan of care could be as simple as saying, have them come back because we really have to discuss this further, or it could be Dr. Friedman or Dr. Lipshutz is going to do an embolization, and so is going to call them and set that up. And again, hopefully this is just an opportunity to see a little bit about how that works. And I don't know if this will be terribly beneficial in terms of understanding carcinoid tumors or liver cancer or those kind of things. What we're really hoping for is to see how things work in the real world inside of the Monday morning meeting. And inside, I don't need to tell you this, but this is part of why these tumor boards, or we shouldn't call them tumor boards, that's probably the wrong word. A tumor board in the medical world means that a cancer type is brought to a panel of people, some of which know the patient, some of which don't, and they discuss it, and they talk about diagnosis and this and that. This really should be called a working group, or a multidisciplinary working group, because everyone around the table knows each patient. In fact, usually 3, 4, 5 of us know the patient individually. So I shouldn't really call these tumor boards. These are working groups. Why are CNET tumors so useful for this model? Unique biology, unique symptoms and syndromes that only a handful of people in any medical center know about. Long survival times, thank goodness, but this is times that there's many interactions, many interventions, many treatment changes over the course of the treatment. Some cancers, it's take it out and then give chemo, and that's pretty much it unless it comes back. You all know this is a lot different. There's 5 or 6 things to choose from at each point in the road, and thankfully that road goes on a long, long time. We have rapidly expanding options, so that each couple of months when we get together and meet, we need to update ourselves about what's new and how did the last case go and how should we do things differently in the future. So it's a sort of a form of internal education. And of course we know there are phenomenal patient networks, highly motivated, and sometimes patients with these conditions, rightfully so, feel a little bit disenfranchised. Maybe their local doctor doesn't understand their tumor. They told them it's the first one they'd seen in their career. And again, that's part of the reason that having a core group at a center like Cedars, I think, is really important for this tumor type. Because if not everyone at Cedars understands carcinoid or neuroendocrine tumors, there's a group of 10 or 20 of us who deal with it all the time, and that's what we try to bring together. So again, you don't need to see this. Who treats patients? The surgeon, the oncologist, the interventional radiologist, the endocrinologist, and the list is long. And in some way or another, every one of these people comes to our Monday meetings. They're not all here today because we don't have enough chairs, but this is actually this morning's meeting. So I stood at the back of the room and took I'm not in the picture because I was taking it, but this is a typical meeting. And round table, we're all there. Dr. Wachsman is typically up here running the computer, meaning he's running through the images, and a case is presented. We discuss the pertinent factors. We discuss what happened in the past. We all know the question at hand. The question usually is, well, now what? But sometimes the question is, how did it go? Should we do something differently next time? Where should we start? And so again, what we're going to try to do today is give you some examples of the questions that get asked and hopefully answered during those meetings. So real quick about the team, and a few of these will be here today, but most of these you know. Dr. Yu is right here at the table. He's the director of the program, endocrinology. Dr. Hendifar is hopefully on his way if he can find his parking, and he's from medical oncology. Hong Zhou is not here. She's a nurse practitioner for Dr. Hendifar. I'm here, and Dr. Amersi, so I focus mostly on liver and pancreas. Dr. Amersi, surgical oncologist, obviously has expertise in breast and other cancers. Dr. Calhoun is listed here. Dr. Calhoun is moving. He is going to USC, and he will be going to USC, we're not for sure, in March sometime, but this may be the first some of you have heard of this, and this is the second change I was alluding to. He is going to be moving on to take over their transplant program, and again, he's let us know that he may maintain an office in the area, but he won't be technically part of this group here or a Cedars faculty member. And I don't need to tell you how incredibly valuable Dr. Calhoun's contributions have been to the establishment and growth of this program over the last decade. But, times change and people move on, and that's what Steve decided to do. For purposes of our program, you should know that you certainly have the option of seeing Dr. Calhoun, because he's only 10 miles away, at his new practice, and again, he'll send out a letter separately. But you're also welcome to continue to see any other member of the group at your own discretion. It's totally up to you. We don't try to influence you one way or another. But this core group that you're seeing here is the Cedars-Sinai Multidisciplinary Neuroendocrine group, and we're still here. And if any of you say, well, we want to follow Dr. Calhoun, please, we'll maintain whatever relationship you'd like. If others say, no, we really want to stick with the Cedars group, then that's us, and we're happy to do that. And I'll still be in this building, and we can have that discussion later. But I want you to know that that's a fact of life. And we're all good friends and good colleagues, and he'll be right down the road. The Cedars team on the GI side, many of you know these, Dr. Lowe and his two colleagues who do the ERCP and the EUS as they're called. Some of these acronyms may not mean much to you, but Dr. Gupta, Dr. Jamil, Dr. Lowe are that core group. Dr. Mann is this world-class expert on examining the entire bowel for carcinoid tumors. Really probably one of the best in the country. Does a lot of research on that, is phenomenally talented, and she and Dr. Amersi have several publications and presentations at national meetings this year about some of their results. Interventional Radiology, Ash Wachsman, you already know, he's up here. Marc Friedman, hopefully again will find his way. Marc's been here forever. He's the head of the Interventional Radiology group, and certainly at Cedars-Sinai, chemo embolization, portal vein embolization, radio embolization, all these things are things that Marc pioneered here at Cedars-Sinai. Gabriel Lipshutz is right here in front, and Gabriel joined us from UCLA just this year, just July of this year, and brings a bit of an overlap. He's got all of Marc's infusional and what we would call catheter-based expertise, and he also does ablations, heat treatments directed at tumors in the liver, and that's, I should have mentioned, that's the same thing that Ashley Wachsman does. So everybody wears a slightly different hat, but again, that's what Gabriel has brought to us from across town. There's Dr. Hendifar and Dr. Friedman. And Dr. Tuli. One more too. Have a seat. So Alan Wachsman is not here, and Dr. Diagnolo, these are nuclear medicine experts. Again, world-class guys. Really dealing with PET scans, our creatine scans, dotatate PETs, and the PRRT trial. Rich Tuli just walked in. Rich is the head of radiation oncology. So using radiation to treat tumors in bone, in liver, in pancreas, and other places. Pathologists, you've never met these people, but they're a key part. Rich Mertens, DP Dahl. Dr. Medizadeh, some of you know, really is fantastic at managing bowel problems, nutrition problems, dietary problems. And Tony Hodge, only a few of you know. Tony Hodge is an expert in carcinoid heart disease, and is really a fantastic resource, and he gets involved whenever we need him to get involved, and was really a great addition to the team a couple of years ago. Supportive care, pain control, psychiatry. Some of you know these doctors, Dr. Asher, Dr. Wolcott, and Eve Newhart. And of course, Tina is, I don't think she's coming today. She's over at the Cancer Center, and a lot of you know her quite intimately from the monthly injections. So why do we have these teams? Well, again, some of it's consolidation of effort. instead of 18 phone calls, we can make one phone call after that meeting. We educate each other within the group. Very key part of having this team. We learn from each other every single week. We hope it improves communication with you, and I think it has. I think over this few years of time, people sometimes say, well, what did they say at the Monday meeting? And you might even say who was there, you know, and again, that's actually a fair question, but we may not have given you quite that level of information, but we hope this creates one answer from us and not 6 answers from the Cedars team. The group mentality and the group think, well, you know, we do have coffee there. There's some socializing that goes on there. We have FaceTime with each other, which you otherwise don't have. And you may think that doctors all sort of round in packs in the hospital, but we could go a whole week and not see each other except at that Monday meeting. So again, there's some real valuable asset to that time we spend together, and a lot of sidebar conversations about how did that patient do and what should we do next time. So lastly, and again, we'll move to the cases. And this is a common question when I've called some of you after the Monday meeting. Well, who actually made the decision? I mean, so you all sat together, you're calling me with the group decision, but what do you think? Who was there and who actually said I should have ablation instead of this or that? Well, these are just 2 quick examples. You know, there's a patient with liver masses. You know, you could do nothing. You could ablate. You could remove. You could infuse. You could inject. And don't read these. These are just 100 options you can do on a couple of little cases. My point being, there are a lot of choices in each scenario, and part of our job is to give you with that follow-up phone call, to give you the recommendation of the group, and you might think of it as options. Give you choice A, choice B, choice C, and I don't think any of us are unwilling to share with you if there was some internal discussion. You know, I've sometimes have said, well, the majority said this, but you certainly could consider that, and if you really want to talk about that more, you should come and you should see so and so. We want to share with you on that level, but you can see there's so many choices at all these avenues. We have to have some sort of group mentality. I said this was the last slide now. So how does it actually work? So an email goes around ahead of time saying what cases are going to be discussed. Sorry, the writing's kind of small here. But any physician can bring any case to the table at any time. Every morning, Dr. Hendifar's got a list of anywhere from 4 to 6 patient names. They're not names, it's all de-identified. It's just your initials, but we all kind of know names. And everyone in the room is a treating physician or a treating healthcare provider. There's no, and that's why we had to give you this example here. You can't really come to that meeting. So names are brought up, they're submitted ahead of time, or new cases are brought by the group. Somebody presents the case. We talk about new information. Dr. Wachsman will run through the scans at blazing speed. Scrolling up and down. Sometimes I wanted to tell you, Ash, you've got to slow down as you move through those scans. You tend to go back and forth, and he's so fast and he's so good at what he does that it's hard for the rest of us to keep up. But we'll get a pathology, a clinical update. We'll discuss. We'll try very hard to have at the end, okay, so a statement. So here's the agreement. It's a verbal thing, and Andrew Hendifar will often be the one that says, or Dr. Yu will say, so here's the plan, right? Everyone agree? And it's not a show of hands. There's been a discussion at that point. We agree on who's going to contact the person or who's going to be the next communicator. So you'll call the patient, or who's going to do it? There's a very deliberate designation. Who's going to call the patient? Come on up here. Have a seat at the table.
Okay.
Yeah, right up here. Front and center. I showed her picture earlier. Hong is our nurse practitioner. And then finally, Dr. Hendifar often will write a little blurb in the medical record. I don't believe that this is accessible to you, but I just found out that you do this every meeting, Andrew. You put a little note in that's very useful. It actually says, here's what was discussed, here's the plan of care, and it's just 2 or 3 sentences, but it helps everybody know that there was an action plan agreed upon and then to be carried out. So, all right, so everyone okay with that, with this model? We're gonna try to be as true to form as we can. And yeah, it'll be a little bit gimmicky, a little bit like that, but I don't know what else to do. So I'm gonna bring it. So there's 3 scenarios where we really like to discuss things at that group meeting. And it's sort of obvious, but I'm just going to say in the first scenario is where we're following up some treatment that we did. We want to say, here was the plan we agreed upon 3 months ago. Here's how it went. Just educating, updating, and informing. So a follow-up to a prior treatment. That's the first scenario. And of course, that leads to discussion about, okay, now what? The second scenario is if there's been a change in a person's otherwise stable disease, and now we need to figure out what to do. So the second is we need a new plan, and the third scenario is a brand new patient. We're going to try to, and I don't mean to nitpick, but that's really why we have these groups. So the first case is going to be, notice I put at the top, follow-up of prior treatment. And this is going to be a case of liver tumor from a pancreatic, spread from a pancreatic tumor. And this is exactly how we would talk. So I would show up and they'd say the first case is right here. And I'd say this is a 67-year-old female. She had, I guess her history goes back about 10 years. And again, don't focus on the reading. Just listen to what I'm saying. That's only to remind me what to say. And this is exactly how I would talk. I would say 67-year-old female. She had, about 10 years ago, had liver masses that were identified. Somewhere along the way, they biopsied that and proved that it was a neuroendocrine tumor in the liver. She had a variety of thoughts about workup, and we discussed her here. But ultimately, we agreed on trying to remove the tumors because of we didn't think they were amenable to any other form of treatment in the liver. She's had a surgery in 2010. She then had chemoembolizations. So you guys got to help me here. We gotta put on. So here's what we did. So the tumors were in the middle of the liver. We looked at her films before here. We thought that if we tried to do chemoembolization, we wouldn't be an effective response, and so we took her for a cytoreduction, and we did one of these enucleations, as we call them, where we took out 60 or 70% of the tumor the first time, recovered great. And then Mark, you did 3 chemoembolizations that I never really understood why she didn't respond very well. Do you remember that case?
My recall is that the part of the left lobe was gone, and she had fairly extensive residual disease in the liver remnant. And at that time we thought regional therapy was a good option. We considered chemoembolization, radioembolization. I think the degree of involvement sort of pushed us toward chemoembolization, and at that time we went forward with going forward with LC beads with doxorubicin. For whatever reason, the results were not as good as we were hoping. I'm not sure exactly why that is. Her tumors were very vascular, and it's not really clear. We treated everything but the left side. The left side really did not look like it had any significant residual disease. So we thought about maybe repeating the therapy, but I knew from the previous cases that the embolization had been rather complete. So we discussed possibly doing trying to find new branches that have grown into that we're supplying the tumor now, but that has somewhat of an increased risk of non-target embolization and complications. So at that point, we felt probably that surgery was the better way to go.
So Gabe, she had a pancreatic head mass, and we were nervous about doing a Whipple because of we have to connect the intestine to the liver. We thought if we did the Whipple, then she couldn't have chemoembolization. So we did the chemoembolization before going back and taking out the pancreatic tumor. Did you do the same thing at UCLA before you came?
It did the same thing as far as.
Would you be nervous about chemoembolization in someone who had a Whipple?
Yeah, you would be. You worry about the not having a biliary sphincter, and you're at increased risk of infection.
So that's what we thought. We actually did the second surgery, which we're trying to stall here while Ash brings up the films. So we did
this is typically what happens.
we did this. This does happen. Things malfunction. So we did the second surgery. We did the second surgery and ablated and removed a few more. We found that the mass didn't require a full pancreatic resection. We were able to just peel it out of the liver, so we didn't have to use any biliary stents. So that was a nice surprise. We were able to not do that bigger surgery, and what we really thought was leave all the options open. So the film, when we get it, is gonna show a bunch of tumors still there, but they're remarkably slow growing, and she's been on octreotide. She's asking me, what else should we do? What, lanreotide, pesreotide, Avastin, Temidor, Xeloda, we got 100
so-
choices.
So one of the things we talk about in the conferences, especially with patients, and many patients are here on octreotide, are the different types of options we can use. What is the studies, what are the current studies, what is the current thinking around the country regarding the best approaches to the disease? And, we'll talk about the risks and benefits, including, the evidence of the PROMID studies and the Clarinet studies that just came out in pancreatic neuroendocrine tumors that show that using octreotide can help delay progression and help improve outcomes. So we'll talk about that as one possible options, or other clinical trials that we have available through our cooperative group studies, including looking at Temidor and Xeloda for pancreatic neuroendocrine tumors. And other options including PRT and other types of treatments.
So Ash, can you just go to the top on this one? Because I'll tell you one of my concerns. One of my concerns is this one spot, you can show right by the right hepatic vein on this, just scroll down a bit, because I want to ask Rich about this. This is after our prior treatments. There's a little bit of tumor right by the vein there, Rich, and I don't know whether we can get it in any other way. Should we radiate that? They're not growing, they're quite stable. We certainly can radiate the liver, but it's hard to get there through any other approach. What do you think?
Yeah, I mean, it's certainly technically feasible with the advancements that we've seen in radiation recently. I think the bigger question is it the most appropriate treatment?
I'm trying to get you to speak up.
So it's certainly technically feasible, especially given the advancements that we've seen in radiation oncology recently. I think we could treat that area and do a pretty good job in helping it disappear and not come back. I think the bigger question is, in the context of the other things that are going on in the liver, would it be the most prudent thing to do at this point?
I mean,
Meaning-
it's not growing, so
Right.
our inclination was sit tight, leave it alone. None of these things are close to critical structures, so we thought even if it grew 5 or 6 millimeters, we'll have all the options open. And I would ask Dr. Wachsman about ablation, but he's got his hands full, so.
Well, I can help you.
I
So-
should say, by the way, he joined us for both of these surgeries, so he's, as he often does, he'll often come into the operating room and assist with these, so.
Okay, so looking at this, well, some of these lesions are fairly straightforward to do for an ablation technique. For instance, this lesion here in the lower half of the right lobe of the liver here, this lesion certainly accessible from a percutaneous approach. We'd come in here laterally and just come straight into the lesion with 2 or 3 needles just to take that one out. Certainly looks like there's enough space around it for margins to get a clear margin around this particular mass here. Some of these, now, if there wasn't that many tumors that we're worried about, or if we're just worried about the rate limiting lesions, then we would pick the largest lesions to treat. Certainly this one's easy to do. Up here at the dome, it's a tough go, but it's not impossible. We could probably do this percutaneously. We just have to use longer needles, and we're doing it under general anesthesia, so it actually works out pretty well that we can potentially get it. Sometimes to get the entire margin, this lesion here might not work as well, only because of that's the vascular pedicle coming into the liver itself. So for us, this lesion might not be a good candidate for ablation, because the bile duct that you need to drain the liver is right there, and it causes this stricture. So I'm worried about that one. This one potentially can be done. It's a treatable lesion. Can I get the entire margin? I'm not so sure. This one down here, more inferiorly, I think I can get that really easily. That's not a problem.
So by
I
ablation,
would,
sorry, go ahead.
I would like to just say a couple of things about this. I think the plan, I would argue that, waiting and seeing is the best approach. However, in the future, with the position of that disease that's along the diaphragm, which is somewhat hard to approach with these various techniques we're talking about, it's very likely that the blood supply to that tumor specifically, and those that are near that area, are coming from the artery that feeds the diaphragm, the phrenic artery. And therefore, that would represent a conduit for which we could deliver additional chemoembolization, maybe not the beads that we've used in the past in this patient, but a different kind of chemotherapy that would be an embolus that would be well-suited for that anatomical location.
So Andrew, she wants to know about PRRT, as does just about everybody. So does she qualify for any of our trials?
Well, for pancreas neuroendocrine tumors, for any PRT therapy in general, the first thing you need to make sure is that the uptake on the octreotide scans. We'd have to review that, and if there wasn't an octreotide scan recently, we'd have to get one.
But it's
And
not growing. I mean, why, just leave it alone, right?
Right, so if in patients who have stable or slow-growing disease, we would not look into PRRT as a treatment.
And you can only do that, once you do it, you gotta do it. You can't do it over and over and over. It's that one-time treatment, right? So, all right, so we agreed, we'll just sit tight. We'll keep her on octreotide 30 once a month, follow every 3 months like we've been doing. And I should ask Dr. Yu, because we haven't involved him yet. Are we doing too many chest CTs?
For this patient?
Anybody?
Yeah, well, I think for the follow-up involvement, I will discuss in our group how frequent the follow-up frequency should be. I'm an endocrinologist, I'm a more conservative person in the group, so I think we probably don't have to do all the too frequent imaging. I know Dr. Warner used to do every 3 months. I would say every 6 to 12 months actually probably would suffice.
I think actually every 6 for this abdomen is probably okay here too. These haven't grown at all in a year, maybe 1 millimeter this last time. So we'll go with 6 months. And then if it grows at all, I'll bring it back and we can talk about all the different options. And I'll give her a call. So, all right? All right.
I
So
mean,
that's, sorry.
I mean, for CT chest, it makes sense because a lot of times mid-gut carcinoids, the pancreatic neuroendocrine tumors, they go to the liver, they don't go to the lungs. They don't really see bone metastases that often. And when we do, we can pick them up for most of them.
All right. So that's, what's that? Well, again, I don't want to focus too much on the case. We wanted to focus on the process. I mean, we can take questions, but it's not really the idea here. So what we're trying to show with that case is this complex anatomy, really complex anatomy, 3 prior therapies, and you could never read from a report the nuances of those films. But when we see them, and Mark pointed this out, because it's touching the diaphragm, that opens up a whole new set of treatments. Gabe pointed out a little bit different approach at another center. And, so seeing the films, scrolling through them slice by slice, comparing them in the past, hearing the whole story, ultimately we come up with the plan to sit tight. We'll change our monitoring. It's a little overkill to do it every 3 months. We're going to change it to every 6 months. And I'll contact the person because I was the one that brought it to the table and I've known her through all these surgeries, so I'll continue to be the point person. And our next follow-up will be in 6 months with a new scan at this meeting. And that's the end. I mean, again, we can break later. We can talk about ablation and all this and that maybe at breakout meetings. But let's move on. Let's skip the next case. Go to so this is a new patient, and again, Andrew, I'll let you just as we would on that day. So I've never met this person, only
Right.
Andrew and Farin. But let's have you.
So yeah, so this is a 62-year-old woman who came.
And everyone's got to speak up because I can tell people in the back have a hard
Okay.
time hearing.
I'll speak up. So this is a 62-year-old woman who came to us for a second opinion. She's had abdominal pain for a year, and they did a scan. They saw something there. They weren't sure what's going on. Decided to follow it. It was a mass. And then she ended up in the hospital with an obstruction. About a year after that, they ended up biopsying it. She was diagnosed with a neuroendocrine tumor. And so, she had some chemotherapy because it was called a high-grade neuroendocrine tumor. Not much more information was known about the tumor, and when she came to see us, we went through our usual process of getting the pathology, getting all the scans from the outside center, sending it to pathology, and discussing it in our tumor board.
And you've got scans on her?
Yeah.
So Andrew, this is supposed to be a small bowel primary,
Right, so the primary was not clear from the imaging or from the primary team, but they did call it a high-grade neuroendocrine tumor. Their plan was cisplatin etoposide. The patient had a few cycles of treatment. She did not tolerate the treatment well, and she continued to have symptoms in her abdomen. She continued to have pain and almost obstructive-like symptoms when we saw her.
But she has no diarrhea, or flushing.
She had no diarrhea or flushing and no real evaluation of the GI tract extensively.
Is that a common regimen? So we talk a lot about chemotherapy, and then one of the things we talk about is whether people got something we would consider to be normal. I don't, is that common?
Yeah, I mean, usually for cisplatin etoposide, only for very high-grade neuroendocrine tumors. Most of the neuroendocrine tumors of the small bowel, which we thought based on the history and the scans, only about 10 to 15% of those are very high-grade, requiring chemotherapy. So we just wanted to make sure that everybody was going in the right direction.
She had already come to us on having had 3 cycles.
Right, right.
In fact, by the time Dr. Hendifar and I saw her, she'd already lost 50 pounds because she continued to remain obstructed. She was evaluated by a surgeon at the outside hospital who was very uncomfortable about operating on her. So she's just been on a clear liquid diet through the entire time that she's been getting the chemotherapy.
What do you got, Ash?
Okay, so this is an MRI that was done in, this is my first MRI here, so from July of 2014. Just going through the images here, I see a number of mesenteric lymph nodes that are borderline enlarged that potentially could be involved by disease.
Sorry, can you speak up just a little?
Yeah, okay. So I see a number of lymph nodes that are enlarged that could be involved by disease here along the rid of the mesentery. This is where the superior mesenteric artery and vein are. That's the major vessels that feed the small bowel. And then leading toward this, next to the cava and the aorta, there are lymph nodes in this group as well here. When we do the delayed images on the EOVIS scan, we see, sorry, let me get down there. The delayed images are the most important images in the way for the sensitivity for looking for liver lesions. And these show the washout of all the different liver lesions that might be found, and often are often occult on CT scans. So, and even the early phase images didn't really show it well, but you can see all the different lesions that might be that are in this liver.
So Ash, do you know if this is growing or this is our first scan?
This is our first scan, and then the second scan. I'm going to put it up here. This is our second scan here. Same sequence.
And this, by the way, I'm going to just yell out. This, what we're doing right now is really an important part of this meeting. The ability to have side-by-side images and have a radiologist there and scroll through them side by side is absolutely critical to this whole process. And it's invaluable what we gain from these 2 minutes that we spend stacking A against B.
So here we can see, this is the same slide, same level roughly, different time points, but you can see this at least 3 or 4 lesions here on the left, 5 or 6 lesions on the right, but they're more conspicuous on the newer scan than they are on the older scan. And I think they've gotten a little bit bigger. You can see that's bigger than that lesion there. And this one is definitely bigger than that lesion there. And as we scroll down, we're looking at some lesions there. But it seems to me that there's definitely more lesions. They're more conspicuous. It's not related to the timing of the bolus. So I think there's been an increase in growth in number in this.
And she's losing weight and any obstructive symptoms?
She definitely was, because she was terrified to eat and had been the whole time. By the time she started chemo, she lost about 30 pounds and then another 20 thereafter. So she basically changed her diet herself. Anytime she'd eat regular food, she'd throw up. So she lived on a full liquid diet.
So what should we do?
So when she came to see myself and Dr. Hendifar, obviously we knew that there was a small bowel primary, but the most important thing is to make sure that she doesn't have multifocal disease, meaning more than one primary. So obviously you can find the area of obstruction on when you go in for surgery, but the most important thing is to make sure she doesn't have more than one primary, because it obviously affects the extent of surgical resection. Now, small bowel primaries can occur on the surface of the bowel or on the inside of the bowel. And as surgeons, yes, we look at the entire surface and we run the small intestine, but it's important because some of these lesions are so small. And for her, I think the decision was, when we presented her, GI was in the room, and we referred her to Dr. Mann to do a double balloon. So this was a patient who we had assumed had one primary, and on double balloon ended up having close to 15 separate primary carcinoids that were found in her small bowel at the time of. So it gave me a better idea in terms of planning. But in terms of, when we presented her, the question was obviously, should we do something with the liver at the time of surgery, or should we do chemoembolization later? Obviously, the issue is she's lost a tremendous amount of weight, putting her through big surgery. So the right thing to do is to combine something, or should we do other liver-related therapies after? So.
What was all of the tumor basically resected that was in the abdomen?
Sure. So I when we presented her at conference.
But let's just,
Yeah.
let's just pretend you hadn't operated yet. This is the film. We've got this film, we've got a person that lost 50 pounds. The key of this conference is we're now gonna discuss a really complicated case. We now know she has 15 small bowel tumors. What should we do? How do we sort this out as a group? She lost 30 pounds, she got a moderately differentiated?
Okay, so when we reviewed the pathology and after the surgery, we realized that in the primary site, she has a low-grade neuroendocrine tumor, not a high-grade neuroendocrine tumor. So it changes the options a little bit. So chemotherapy comes down in our option list.
But again, in terms of that day, this film,
Right.
patient 30 pounds, what are our options?
I think the issue more at hand is actually first the small bowel. I don't think she has the option really of not addressing the small bowel. She's had obstructive symptoms for months. She's really not eating. So I feel like at this point, addressing the small bowel first may be a priority rather than addressing the liver disease.
Big surgery or little surgery?
Well, the concern is obviously she's got a mass at the root of the mesentery, the extent of small bowel resection. But looking at the scans, she definitely looks resectable, and she responded slightly to the chemotherapy.
So you're gonna do her open
So,
surgery?
given the extent of disease, if this was only small bowel, where it was just mesenteric nodes, I would do it laparoscopically. And the advantage, obviously, laparoscopically is much more easier recovery for patients. And you can't, patients do ask, well, if you're doing it laparoscopically, how do you make sure that there aren't multiple primaries? The best part is the small bowel is actually not attached to things in the abdomen, so you can eviscerate, meaning take it out through small incisions and actually milk the entire small bowel just to make sure you're not missing any additional lesions. But with her, given the extent of disease, I really felt an open operation was the right thing to do, given that I had to do a mesenteric mouse resection.
And there's not much point in taking liver out? You need us to be around, or just you'll take care of it? Because there's not much liver, it's all small liver disease. It's
Right.
probably better to leave that for Dr. Friedman and Gabe to handle later. So he's last name, your first name. Dr. Friedman, Dr. Lipshutz to handle later.
So thoughts, Mark, do you think?
Well, I think from morphologically speaking, I think the patient would be a candidate for radioembolization. That's what I would think would be the best way to treat the liver disease. So the way I understand it now is she doesn't have any known residual abdominal peritoneal disease.
Right.
And she's basically left with no distant metastases and what's left in the liver. So I would argue for radioembolization in what will, require a mapping angiogram and then bilobar sessions
After
with
small bowel
radioembolization.
surgery.
Right.
Yeah, okay.
So Dr. Hendifar, so the liver biopsy was a core biopsy or was a needle biopsy?
It was a needle biopsy.
Yeah, so needle biopsy often return a false positive, very high Cas7 labeling. In light of the low Cas7 in the primary, and with the sort of not so rapid growth rate of the liver metastasis, I would reevaluate the true grade of the tumor. I think likely the 37 is a false positive result. So I think you would really want to get the accurate grade of the tumor, which would do a core biopsy.
Do we need more imaging? Do you want her to get a dotatate PET? Doesn't really change
I
anything.
don't think it would change anything in terms of her management. She needs to have the small bowel resection.
Octreotide scan? She already had one, or she needs one?
She needs one.
She needs
So
an
what-
octreotide scan, okay.
And then CT angiography is something I've been pushing lately, been wanting to do, is more to look at CTs, to look for small polyps and looking for lesions. It's a CT scan instead of an MRI. We do enterography where we're looking at the small bowel with the MRI, but we find that CT actually gives us a slightly better resolution when it comes to the small bowel itself. Also, it's faster imaging, so we can so bowel, when it's moving a little bit, will be less apt to give us any problems if it does move a little bit. when
But
we're
can
taking
she
the
get
picture.
enterography with an obstruction?
she can get an enterography with an obstruction. She just has to drink some water or drink some Vollumen, which is a neutral oral contrast material. We give them an injection of contrast, and we look to see what tumors will light up. And oftentimes, carcinoid tumors will light up on an enterography study, and I think on the outside it might be a reasonable first choice. Because the MRIs and are good for surveillance and looking at lymph nodes, and they're good for solid organ pathology, and it's excellent. It's really amazing. But I think small bowel, sometimes if we're looking preoperatively, I think the enterography, the double balloon enteroscopies are excellent, but also I think this would be a helpful mapping tool to give you an idea of where to look when you're going in for laparoscopy.
So the plan will be for surgery, does she need cardiac workup, any carcinoid heart disease, or does she need to see Dr. Haj?
She had an EKG done, it was normal, she actually has no other comorbidities.
She's good to go.
Yeah, and we did do a pre-op CT scan.
So
for
you'll
chest.
get in touch with her, you'll set up surgery, and we'll
And then
talk about her
we'll
again
talk about
after
it
surgery.
and then decide what to do for liver
Okay.
disease.
All right. So that's the end of that case. So again, I'm trying to keep us focused on how we make the decisions. That comes to a close. Dr. Amersi is going to call the patient, set up surgery. Preoperative testing is left in her hands. The group breathes a sigh of relief, and we move on to the next case. We're not going to do any more cases because I think that we've made our point. But I wanted to show just a few slides, if I could, while the group's here, about not about cases, but about this multidisciplinary concept. So, you know, we've had this in place for a couple years now. We think it works pretty well. What you've told us about, and again, this is from conversations I've had, and I invite the group, what they've heard, and part of the reason we were excited about this opportunity is to hear from you about, you got us all in one room. You're not gonna have this again till another meeting down the road. So I think we're all happy to hear nudges, maybe not, you know, real loud complaints, but nudges and ways we can do better. These are 4 things I wrote down that I think that has been made clear to us. You need to know that you need confidence that we have connections to clinical trials, to the network across the country. You need to know that that people in this room are leaders in the field, academically and clinically, that we need to be reachable and of course willing to reach out, and then that we will work hand in hand with the carcinoid community, education outreach and the journey. And the first one of those I mentioned was clinical trials. Andrew and I were going over this list. There's, I don't know, 6, 8 active clinical trials at Cedars in carcinoid disease. Some of these are completed enrolling, but are follow-up. Some of them are actively enrolling. Any comments, Andrew?
Yeah, exactly. And you know, we constantly look out for the newest clinical trials and opportunities. We have people from pharmaceuticals, cooperative group, as well as our own investigator-initiated studies, which we're actually focusing on now, is trying to develop our own studies for the Cedars patient group.
Many of you know we are looking for a new oncologist, and that'll bring a new study nurse to replace Dr. Wollen's nurse and new clinical nurse. So there's a small personnel gap right now that will be changed when that new person arrives. But we do have a lot of clinical trials, and we all know we can do a bit better at showcasing them and making sure you know what they are, and making sure that we're connected to the rest of the community around the country. And I put up here some thoughts on that, and I addressed this with the Orange County group when we spoke down there as well, about other ways we can keep that process transparent and active. In other words, that we've got clinical trials and we're connected to that network. And of course, that's something Ed Wollen had very well, but remember, Ed Wollen moved to the other side of the country. He's still available by phone. So he's still a dear friend of ours. Leaders in the field in terms of academic and clinically, well, you may not know it, because again, we haven't come to you in this way before, but you've actually got a lot of them right here. You got Dr. Yu, Dr. Hendifar, and me in terms of liver and pancreatic disease. Dr. Amersi's published and presenting at national meetings this year on small bowel tumors. Marc Friedman, and of course Gabe just joined us, has publications and has brought these procedures all to Cedars-Sinai, and this is leading edge stuff that's available here. This is just a list of some of the publications out of this group, and these are not Ed Wollen's publications. These are non-Ed Wollen publications. So this is other people in our group, and it's pretty robust. It's a pretty robust list of publications. We need to be reachable. Well, again, you've told us that you still have that old number, that 423-0709. That number still works. We have we have been promised by the administration of the Cancer Center that we will have a new navigator in place. Oh, I put the wrong date. Should be in place somewhere in the next month or so, a new patient navigator to help deal with the calls that are sometimes being missed, to make sure that there's a live person answering the phone, to make sure that you're not wondering where your voicemail ended up. And this is a legitimate commitment from the head of the Cancer Center himself, who we're just trying to work out who it is and what exact title they'll have. But this is a person who will be in place to help handle the phone surge that's kind of missing since Andrew, not this Andrew, the other Andrew, and Ed Wallen left. We also have the option in terms of where you are seen and where your care is at while you're looking at a real asset now to Cedars-Sinai. This building is available right now for clinic visits. So that's where I wrote, this is a clinic space. I see patients here. Dr. Amersi, Dr. Hendifar, Dr. Wachsman have all traveled over here to see patients. We're going to try to figure out a way when it works best for you that Mark and Gabe can come over as well. Well, it may take some arm twisting, but we'll just figure it out. And remember, we have Skype and we have video conferencing. We have all kinds of ways to take advantage of this facility. And again, you have access to that officially as of right now. How? Because this is the Liver and Pancreatic Cancer Treatment Center. So that's a new option to be seen here. And again, we can talk about that more, but it's real. The building exists. And again, there will be a new oncologist. So we are going to be more reachable with some quick stopgap measures, and hopefully that change will make it very clear that your calls will get answered, you won't get missed. You've got a new building, new clinic space, and we'll try to even make our outpatient visits multidisciplinary. And that's something we talked about 6 months ago, that we would try to see you as a group. And that, for those of you who were in the Cancer Center, when we would have clinics there, it worked pretty well, but you might spend your whole afternoon, you'd see Ed at 11 and you'd see me at 3, and it could be a little bit better. And I think this building maybe, and the Cancer Center still gives us an opportunity to make that a little bit cleaner, where you could see, again, let's say you had a small bowel tumor with a liver tumor, and you were on octreotide therapy. I don't think there's any question you could see Farin, Andrew, and me in an hour-and-a-half, 2-hour time slot, either here or over there. So I think this building gives us a lot of flexibility. That's actually the perfect question for not me. That's the perfect question for this navigator. Because who do you give that question to? Do you call Andrew? Do you call Hong? Do you call Mark? We all are kind of running around during the day. That's why we need the navigator. I don't actually have the answer for you, but I know where to get the answer. And I know who's got the answer and how to pay somebody to have that position to really reach out and be the person to answer those really, really practical questions. That's what we're going to make happen. We're going to make it happen. Lastly, working with the CNET community, well, you've got this building at your disposal 1 day a month. That's all we can give to you. We'll have the annual meeting that Giovanna talked about. And again, this is the last line of this little presentation of how else can we help and can we work jointly with you. And again, I already talked a little bit about Dr. Calhoun's transition, and again, that doesn't need to be awkward. That just needs to work out to the best of what you want for those of you who had been under his care. And that's part of the value of the group. So one of the things that comes up is exactly that. And that's kind of why I threw that out there. Are we getting too many chest CTs? That leads to actually a research project. So now we're going to try to get one of our other colleagues to look at all the chest CTs we've done to see if that actually was productive or not. That's how this internal work sort of feeds on itself, this internal group. Are we getting too many scans? Let's look at it ourselves. Let's see what our own results are. Let's search the literature. For now, we're going to do X, Y, or Z, and then that comes back to the patient. I've had plenty of patients say, thanks for the advice. I like getting scans every 3 months. We may go back and forth a little bit on that, but we're not going to draw a line in the sand. Okay, you want to see us more often? We'll see you more often. Okay. A lot of the discussion comes around some of the points you saw here. Bowel surgery alone, bowel surgery with another surgery. Difficult liver tumor, should we watch and wait? So I use the word group think when we have, and sometimes our whole group, you know, if you go back several years, actually historically, we've been very aggressive at trying to get rid of liver tumors. We just as a group believe that the less liver tumor you have, the better off you'll be. So does that mean that you chase every 1 centimeter spot if there's 3 or 4 of them? No, that's probably overkill. But if you go back 6, 7 years, we sometimes did that. We sometimes pursued this. So we've changed here and there as our techniques and have evolved. So how do we solve it? How do we resolve it?
I think usually we don't, it sounds like we come up with one answer, but usually we come up with a few answers and we rank them based on what we think is best. And the answers aren't always final. Of course, we have to talk to everyone in here. You guys oftentimes will help make the decisions for us. But, you know, it's interesting. I think since we're a pretty cohesive group and we all work together really well, so we've been lucky that we haven't had too much of a problem with that.
And in some cases, there are just certain unknown factors there, and so nobody really knows the best answer. So we have to address a specific treatment based on the patient's unique situation. That we talk with you and to tell you what are the pros, what are the cons, and what are unknowns, and we make a decision eventually.
Some of it's programmatic. It's our preferred way to treat a certain scenario. And usually we'll admit that. I mean, when we call you up, we'll often say, look, our thought is this. That equally valid, although not one we usually use, is option B. And you may say, well, what would you do? And a lot of times, by the way, you say to us, what would you do if it was me? Or what would you do if it was your mother? Well, you know, again, exactly what I'm telling you. Otherwise, well, I should tell you that, you know, that we're all prepared for that question. So you may think you're catching us off guard, but that's the answer we already gave you. We gave you the answer that we would typically do for our loved one and our family member. But it's a fair question. These are not. It's not just. We try to avoid actually giving you just one answer because that's phony. You know there's got to be some discussion and a little bit of internal debate. Plus, times change. Where does PRRT fit into the equation? You know, where does radioembolization versus chemoembolization, and what order you do them? I can tell you, we spent hours discussing in that meeting. Should we chemoembolize first and then radio, or radio first and then this? And it changes over time. You know, Marc and Gabe will go to their national meetings and come back with new thoughts and their own experience. That gets brought to the table every week. And it may change a bit. And it'd be a very fair question. Why did that change? Well, you know, in our last 60 of these, we thought the risk was so-and-so, but we've realized that it's not. It's way safer than we thought, so now we're doing it this way, this way, this way.
I think that multidisciplinary team approach really is helpful, because we talk amongst ourselves and we come up with a decision that makes sense. When we talk out in the community, and there's others that are in our community that work with neuroendocrine tumors, they may not necessarily see eye to eye in terms of what we say to them, or vice versa. So we try to bring bring an input of a multidisciplinary approach to them and tell them what we offer, and at least give them the option of listening to what we have to say as well. And I think also imaging in general, just, you know, it's one thing, we look at films, we take pictures, we look at them, we give you a report. Looking at the report and actually reviewing the images in person with others, it really does bring you out and show you more detail as to what is really going on in detail about those pictures and what's happening. I think it's been helpful.
I think we would all admit that we can do better at being part of that national dialogue. The big thing we're going to strive for over the next, really going to be 12 months. That's not a 1 month fix. This is a 12-month fix, is to improve our web-based, not only presence, but resources. Whether it's trials, whether it's blogging about things, whether it's, we talked about, you know, our monthly CME meeting, maybe somehow making some of that content accessible in an educational forum or format to people who really want to understand the scans and that sort of thing. You know, there's different ways we can do that, and that's maybe we don't need to make our list right now, but we all know that the internet is a big ally, and we need to, as a sort of a 12-month project, make better use of it.
The gallium scan, you know, I don't, the
Thank you,
problem with
Mark.
the problem with the gallium scan is that,
And maybe it's not, I don't know. Thank you.
I think that it's not a scan that's probably, it's working its way into the commercial use, but it's not there. So in the meantime, it's only available at research centers, and because of that, not that many people know about it. Yeah, I think we send more patients to UCLA than UCLA sends. Their first 100 patients, 99 were from this group. Yeah, so we've been, you know, we've been actively involved in that, and we're doing our best to be part of the national conversation. We do, you know, we have patients in common with Dr. Odorizio all the time, and you know, it's just hard. It's just a hard. It's hard when it's a unique field. It's hard when there's not that many people who know about it.
But that gets to another struggle, and that is separating fact from fiction, and fact from
Exactly.
fiction, and hype from realism. I mean, you know, it's we don't yet know where that scan will fit into our clinical practice.
Right.
We have this discussion every week.
Yeah, every week.
And you may not want to hear this, but we actually will call each other on this. You know, Andrew will say, I really want to send him for dotatate PET. And you know, someone else will say, what's it cost now, $3,000? I mean, and does it really change your management? Most of the time, the answer is not a bit. Doesn't change anything, but it's good to know. Okay, it's good to know. But that's the challenge, right? I mean, you might say, why not get it? It's out there. Okay, I agree with that. It's hard for me to advocate you paying $3,000 out of your pocket for something that there's almost no chance it'll change my management. So is it a valuable test or not? Sure. I don't quite know where it fits in yet. There's a lot of hype about it. Doesn't change too much, but it changes once in a while. We may need to know about a lymph node. May affect whether you do a case laparoscopically or not. Might affect
Yeah,
transplant.
that came up. That was a good. one.
Transplant options.
That
Is there a microscopic tumor left in a lymph node? We may not refer that person for transplant, which again is very rare in general. So there's a time and a place.
So if there's an issue that comes up, Dr. Mita or Dr. Natali will, you know, have the patient evaluated by us. Hong usually does a good job of being the go-between and making sure everybody is taken care of in that regard. That happens on a one-on-one basis, because I think it all depends on what insurance company the patient has and what what their thoughts are on transferring the care to Cedars. So I think it's a very individual issue per patient by patient. It's not really not everyone owns HMO is the same. It depends on the treatment plan. If there's a treatment plan that cannot be carried out at Kaiser, then there's usually not a problem. Then they're more than happy to send the patient.
They are.
But if it's a Kaiser, if it's a treatment plan that they cannot do.
But
right.
keep in mind, if it's for pancreatic surgery, so Kaiser has pancreatic surgeons, so they often will piecemeal it. I think that the point person for those arguments is really the oncologist. Yeah, and so typically you can get an approval or an allowance for an oncology consultation. You made reference to this 45-minute consultation. You can pack a lot of information into that dictation, which includes a discussion in a multidisciplinary group, which includes the complexity of the liver treatment, which can make reference to the fact that it ought to be carried out at a transplant center. You know, there's a lot of ways that the strength of that recommendation can be, improved so that it would make total care more likely. We will do that, and we want to do it. We also want to work, collegially with these companies, and if it's a question of them getting a scan there as opposed to here, as long as ASH feels it's a good quality scan, we'll work with them. If it's a routine gallbladder surgery, it's hard for me to argue that we're the only ones that can do that. But we absolutely will fight that fight for you. And again, what we really do in those cases is we can now review all those films. Dr. Wachsman, we can actually have them reread. We can make sure they're good quality, and we're willing to do that. If it gets to the point where it's too much trouble or the quality is poor, then you have a much stronger argument to have the total care here. But you're right, in the middle it creates a little bit of disruption with who's getting the film. And for now, it's a fight we have to fight. But we have people that will do it. I mean, we look at these films, if we don't think they're, in this conference, if we don't think they're adequate, we put that in writing. We simply can't tell what's going on with the MRI. You have to do an EAVIS scan with an interrography at Cedars-Sinai, you know.
And we're more than happy to provide a letter or a statement of medical necessity. That's not an issue at all.
And if I could just chime in on that, there have been many patients who are kind of in an HMO loop and were fighting that and were successful also. So there may even be some patients here today who could speak with you about that. I have one question. I haven't heard after Dr. Friedman for a second, so I apologize if it was asked. But it's so wonderful to have all of you in the same room at the same time. And for us to feel important as patients to have you all here together. And I'm wondering, in terms of making appointments with various doctors, what is the recommended, is there a sequence? Would we like referrals starting with oncology? Or if somebody wanted to make an appointment with Dr. Friedman, can they do that direct? What's the suggested sequence?
So what we tried to put on the poster was 2 contact numbers, which was not meant to exclude any offices, it was meant to simplify it. One is the 0709 number at the Cancer Center, the other is Kelly's number here at this center. But can you make an appointment with Dr. Amersi? Absolutely. Can you make an appointment with Dr. Wachsman just to review your films? That's a little tricky. Can you make an appointment to have him discuss ablating something? Yeah, but that'll typically come from a referral made by our Monday meeting or by one of us. It's pretty simple. I call him up and say, hey, can you see so-and-so? And then sometimes, you know, he has to get approval and that sort of thing. So yes, you can call him directly and make an appointment, but you'll usually do that at the direction of someone who's already evaluated you, oncology, liver surgery, or if you already know him, he may call you himself. Ashley may be the one, or Gabe may be the one at the end of the meeting that says, if we say that we need to ablate that thing and segmentate in the liver, we'll say, can you give her a call? I mean, you know her. Can you know? I mean, we may talk in those terms. Now, if the patient never met him before, obviously, I'll call and I'll say, hey, we reviewed things. I don't think we should go after this surgically, but I'm going to have Dr. Wachsman's office call you, and that's the way it'll happen.
I'll generally defer to the surgeons first, only because give them the option, because resection versus non-resection, make sure the total plan makes sense in general before they go straight to ablation, because I might be the endpoint, ultimately the person who does the treatment, but really honestly, I think the multidisciplinary approach is more valid in terms of systemic therapy versus is it a local regional therapy approach that might be more reasonable for or not. And I think the oncologists and the primary teams are better at handling that and distributing.
For purposes of our program, it'll mostly be Dr. Hendifar, Dr. Amersi, and myself who are sort of dealing, who, if you want to use the word quarterback, you know, it's football season, whatever, if you want to use that expression. Again, mostly oncology, but if it's a liver problem and we're following you long-term for a liver-related problem, I think what we're going to offer is to have your appointments here if you want, and if Andrew wants to see you and he wants to, if he can find his way over here, maybe we can consolidate your visit into one here. Or vice versa. If you said, I'm getting my shot there, can you walk over to the cancer center? Yeah, of course. That's why we need that concierge, that navigator, which again, we are going to get. So it'll still be these 3 main entry points for new appointments. But again, you already know this. You may get calls from Rich Tuli about seeing him for a radiation or others. But that's usually, we want that to be at the direction of the Monday meeting.
Nick, I have to go.
Yeah, thanks, Gabe. Thank you.
Thank you all.
All right, thanks.
I want to thank everyone for being here, including all of the